So basically, the MCC wants you to know how a patient with hypercalcemia as a result of cancer and how a patient with hypercalcemia from other causes will present, okay? And we are learning that hypercalcemia is a relatively common presentation, relatively common problem. And the reason why patients will present with hypercalcemia is because the body has a way of getting rid of calcium.
Yeah, on what? WhatsApp or? I'm not gonna burn it.
Like in the urine and also being deposited in the bone. Now, if the rate at which calcium is being put in the bloodstream is more than the rate at which calcium is being excreted or being deposited in the bone, then that's when the patient will present hypercalcemia. So what are the reasons why patients will present with hypercalcemia? Number one, if there is accelerated bone resorption. So if there's a condition which is causing down accelerated bone breakdown. Number two, if there's excessive GIT absorption of calcium. And number three, if there's decreased kidney excretion of calcium. So these are the reasons why a patient will present with hypercalcemia. Now, what are the two most common causes of hypercalcemia? Number one, cancer. Number two, hyperparathyroidism. These two things, please write this down. You can't miss this. Write this down. Why will a patient present with hypercalcemia? Two reasons. Number one, cancer, malignancy. Number two, hyperparathyroidism. Okay, so let's get into this question. A 65-year-old gentleman was seen in the clinic for routine blood work. You notice that the calcium level was 4.5, and the upper limit of the serum calcium is 2.52. You would like to know his medication history. Which medications are likely the cause? So basically, the question is asking, what are medication causes of hypercalcemia? Please, I'll give you 1 minute. I'll give you 1 minute to do this. What are medication causes of hypercalcemia? Number one, thiazide diuretics. Number two, lithium. Number three, teriparatide. Okay? Thiazide diuretics, lithium, and teriparatide. Thiazide diuretics, lithium, and teriparatide. These are medications. If you even forget about all the medications, don't forget about thiazide diuretics, please. Okay. Now, how do you differentiate hypercalcemia from cancers from other sources of hypercalcemia? Because the MCC wants you to know that. And the answer is very simple. Calcium levels are very high in patients with hypercalcemia secondary to cancer. If you have a patient with cancer causing the hypercalcemia, usually you realize that the calcium levels are very, very high. Very, very high. So you have a patient who presents with very high calcium levels. One of the very first things you want to do is to assess the patient for cancer. And so you want to ask system specific. Maybe you want to start from the head, come to the chest, go to the abdomen. You know, what are you losing any weight? Are you having any nice sweat? All those things you want to ask about. Now, the most common cause of hypercalcemia in patients with non-metastatic solid tumors is the secretion of parathyroid hormone-related protein. So, if you have a patient and you are thinking, why is this patient having hypercalcemia? And you do your evaluation and you know what? The patient does not have any cancer. Then, or non-metastatic solid tumor. So the patient may have a tumor, but then it is not spread anywhere. Then the reason is because the patient is having parathyroid hormone-related protein secretion, excessive secretion of that. Okay. Now, if another case of hypercalcemia is a patient who has been immobilized for a long time, and you know, at times we see this in our emergency rooms a lot. Patients who live alone, and then maybe something happened, you know, and then they've been on the floor for days. They've been on the floor for days, and they have been like they are unable to mobilize. How will you know that this is as a result of, you know, this patient has been on the floor for quite some time? Number one, you realize that their parathyroid hormone level is low. And then number two, their parathyroid hormone releasing protein is also low. And then vitamin D level is also normal. So it looks like it came from, breakdown of muscle tissue and all those things. And in these patients, if you check their CK level will be high because they may have developed rhabdomyolysis. So in a patient who has been immobilized or like been falling on the floor and been on the floor for a number of days, and then the neighbor says that I've not seen Mr. Adams come out of his room. And because of that, the police go and do, a wellness check and they find that he's on the floor. Or a patient who has had a stroke and the patient has been immobilized. And then you do blood work and you realize that the patient has hypercalcemia. When you do further blood work, because we said the next thing you have to do is parathyroid hormone levels. If you do parathyroid hormone levels, you realize that it is low. Parathyroid hormone releasing protein will be low. Vitamin D level will also be normal. Okay. I have another question for you. I have a question. A 56-year-old gentleman was seen in the clinic for routine blood work. You notice that the calcium level was 4.5. You are concerned about some endocrinological causes of hypercalcemia. List 2. In other words, I want you to know that there are some endocrine causes of hypercalcemia. So please put it in the comment section. Let's go. Endocrine causes of hypercalcemia. What are some endocrine causes of hypercalcemia? What are some endocrine causes of hypercalcemia? Number 1, thyrotoxicosis. Number 2, pheochromocytoma. Number 3, adrenal insufficiency. These are the commonest. There are other endocrine causes like multiple endocrine neoplasia and all those things, but common things are common. Remember, the exam is at the level of a medical student. So we have 2 people who have dropped off. So if you have any friend who wants to join the Zoom link, you can send the Zoom link to the person to join, okay? So now we are now 98. So if you have any friend who wants to join the Zoom link, you can send it to them. So what are the other causes of hypercalcemia from an endocrine point of view? Number 1, thyrotoxicosis. Number 2, pheochromocytoma. Number 3, adrenal insufficiency. Hypercalcemia can be seen in these patients as well. So what is the summary of the causes of hypercalcemia? We said that cancer is very common. Hyperparathyroidism is also very common. So you have these 2 things you have to keep in mind all the time. So what are the common cancers which cause hypercalcemia? Number 1, lung cancer. Number 2, breast cancer. Number 3, kidney cancer. Number 4, myeloma, so like multiple myeloma. Number 5, leukemia. And then we learned about the endocrine causes like primary hyperparathyroidism, hyperthyroidism leading to, thyrotoxicosis, pheochromocytoma, adrenal insufficiency. We've learned all this, acromegaly. And then you can also have patients who take excessive vitamin D and excessive vitamin A, and patients who take thiazide diuretics. We've already solved the question on this. And patients who take lithium, as well as patients who take hormone therapy for breast cancer. Okay, and then you can also have patients who have granulomatous diseases like sarcoidosis, like tuberculosis, like histoplasmosis, and coccidiomycosis. Dr. Betty, are you tracking with me? Are you okay? Good. So we've learned, so you must know cancers which cause hypercalcemia. You must know endocrine causes which cause hypercalcemia. You must know drugs which cause hypercalcemia, and you must know granulomatous diseases which cause hypercalcemia. And you must also know that patients who are also immobilized can also develop hypercalcemia. And other causes like Paget's disease, because we said that if the bone resorption is very high, then that is a problem. And you also have patients who have post-renal transplants, recovery from acute renal failure, and phosphate depletion syndrome. So let's run through it. And other causes of hypercalcemia, we already said a patient who has been immobilized. What will be the level of the parathyroid hormone level? Will it be low? Will it be normal or high if a patient has been immobilized?
Low parathyroid hormone level.
To be low. What about vitamin D levels? What about vitamin D levels?
Normal.
Normal.
Beautiful. Okay, let's go. So a 56-year-old gentleman was seen in the ER after a colleague asked him to come due to his blood work. You notice that the calcium level was 7.5 and the normal calcium is 2.12 to 2.52. Which of the following are some symptoms or signs you will notice? A, polydipsia. B, hyperreflexia. C, hypotension. D, diarrhea. E, agitation. F, none of the above. So in other words, what are the signs and symptoms of hypocalcemia?
Polydipsia.
Exactly. Polydipsia. Because hyperreflexia, is it seen in hypocalcemia or hypercalcemia?
Hypo.
Hypo.
Beautiful. Beautiful. Okay, so how do you remember the signs and symptoms of hypercalcemia? Remember bones, stones, moans, and groans. So remember the ons, stones. That is, they can develop kidney stones. They can come in pain. Bones, osteolysis, because we said that, the bone is breaking down quickly. Resorption. Moans, they are in a lot of, they are lethargic. They have depressed mood. They may have psychosis. They may have cognitive dysfunction. And then groans, they have abdominal pain, nausea, constipation. So please, if you want to remember the causes of hypercalcemia, remember this image. Bones, stones, the patient who is groaning, and the patient who is moaning. Okay? Okay. So now I want to also take you through the signs and symptoms of hypercalcemia. I've broken it down into systems. So the general symptoms, they may have general malaise, weakness, polydipsia, dehydration. Okay, neurological symptoms, they can have confusion, apathy, depression. They may be stuporous, decreased memory, irritability, headaches, ataxia. Metastatic calcification, they can have conjunctivitis, they can have pruritus. Neurologic issues or urologic issues, they can have kidney stones, which we've already read or learned. Skeletal issues, they can have fractures. Why? Because there's increased bone resorption, and they can have bone pain. And cardiovascular causes, why? They can have hypertension, dysrhythmias, bradycardia, QT shortening, and YT waves. And GI causes, why? They can have anorexia, weight loss, nausea, vomiting, constipation, abdominal pain. So please learn the differences between the signs and symptoms of hypocalcemia and the signs and symptoms of hypercalcemia. So if you are investigating a patient with hypercalcemia, okay, initial goal of the laboratory evaluation is to differentiate parathyroid hormone-mediated hypercalcemia from non-parathyroid hormone-mediated hypercalcemia. And the parathyroid hormone-mediated hypercalcemia, it could be as a result of primary hyperparathyroidism. So if the parathyroid hormone level is working too much, okay, can cause hypercalcemia. Tertiary hyperparathyroidism, and then familial hyperparathyroidism. And then the non-parathyroid hormone-mediated hypercalcemia. That means that these patients, they have hypercalcemia, and it is not because of the parathyroid hormone levels. It is because of something else. And we learned that the two commonest causes of hypercalcemia are, number one, malignancy. Number two, hyperparathyroidism. So please, if you have to see a patient with increased calcium level, and especially if the calcium level is very high, because we also learned from the objective is that, one of the features of hypercalcemia as a result of cancer is that the calcium level is very high. So we've learned the parathyroid hormone-mediated hypercalcemia causes and the non-parathyroid hormone-mediated hypercalcemia causes. And we've learned that the parathyroid hormone ones are primary hyperparathyroidism, tertiary hyperparathyroidism, familial hyperparathyroid syndromes, and then the non-parathyroid-mediated hypercalcemia, malignancy, excessive vitamin D, granulomatous disease. Okay, good. So if, like the way we did, yes, Dr. Betty, you're muted. Yeah, unmute yourself. Yeah, you speak. Sorry, I can't hear you. Your voice, we can't hear you. We still can't hear you. We can't hear you. You are speaking, but we can't hear you. So maybe just, just fix your microphone, or you can type your question. You can type it in the comment section, and I'll deal with it for you. Okay, so in the same way that we learned that if you have a patient who has hypothyroidism, the next best investigation you want to do is the parathyroid hormone level. If you also have a patient who has hypercalcemia, the next best investigation you want to do is the parathyroid hormone level as well. So a quick note is, even in a patient with known malignant disease, you still want to request serum parathyroid levels. Why? Because we've learned that malignancy can cause non-parathyroid hormone-mediated hypercalcemia. However, the fact that a patient has a malignancy does not necessarily mean that the parathyroid gland is also not involved. So if you do the parathyroid hormone levels and it is normal in the context of a patient who has hypercalcemia and the patient has malignancy, then you know that, okay, this hypercalcemia is basically from the malignancy. But if you have a patient with hypercalcemia and malignancy as well, and you do the parathyroid hormone levels, and the parathyroid hormone level is also abnormal, then you know that maybe the parathyroid gland is also involved. All right? Okay. So now, let's do some equations. If the patient has increased parathyroid hormone level plus hypercalcemia, increased parathyroid hormone level plus hypercalcemia, think about primary hyperparathyroidism. Simple. Don't think twice. Primary hyperparathyroidism will present with increased parathyroid hormone levels and hypercalcemia. Next one. If the patient has hypercalcemia, but the parathyroid hormone level is low, then think about a non-parathyroid mediated hypercalcemia, like malignancy, like vitamin D intoxication, like granulomatous disease. Doctors, please, before I proceed, is it clear? If it is clear, type yes, 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 because I want to make sure that you're able to ace this in your exam. If you have a patient who presents with hypercalcemia and low parathyroid hormone level, then think about something outside the parathyroid gland, like malignancy, like vitamin D intoxication, like granulomatous disease. Okay, now, remember that we said that if I see a patient with hypercalcemia, the next best investigation is parathyroid hormone level. Now, if I have my patient has hypercalcemia, and parathyroid hormone level is low, what are the differentials which are going to come through your mind, please? We just learned it. What are the differentials? What are the differentials?
Malignancy.
Malignancy, what else?
Vitamin D
intoxication.
Yes, beautiful. Vitamin D
Granulomatous
intoxication.
disease.
Granulomatous disease. So look, if I have a patient who has hypercalcemia, low parathyroid hormone level, that means that is not primary hyperparathyroidism. So I'm looking at these other differentials. And those differentials are somebody who is taking excessive vitamin D, somebody who has a malignancy, or somebody who has granulomatous disease. So then, what is my next best investigation? My next best investigation is that I'm going to check vitamin D levels. Doctors, please, are we all clear? I'm going to check vitamin D levels. When I do vitamin D levels, and the vitamin D level which comes up is the 25 hydroxyvitamin D, then I will ask the patient, do you take a lot of vitamin D supplements? If the patient says yes, then that hypercalcemia is as a result of vitamin D intoxication. Doctors, is this clear? Please, is this clear? Hypercalcemia plus hypercalcemia plus hypercalcemia plus low parathyroid hormone level, I'm thinking about 3 main diagnoses: vitamin D intoxication, malignancy, and granulomatosis. What is my next best investigation? I will measure vitamin D levels. If vitamin D levels are high, especially 25 hydroxyvitamin D, then I'll ask the patient, do you take excessive vitamin D supplementation? However, if the vitamin D level, which is high, is the 125 dihydroxyvitamin D, then I'm going to think about, okay, does this patient have a granulomatous disease or a lymphoma? Then the next best investigation will be chest X-ray. Because remember that lymphoma can cause, perihilar lymphadenopathy. So I'll do a chest X-ray. Doctors, please, is this clear? First, patient has hypercalcemia. What's my next best investigation? Tell me. Please tell me. Tell me. Parathyroid hormone levels. If hypercalcemia plus high parathyroid hormone level, what's my diagnosis? Hyperparathyroidism. Good. Now, hypercalcemia plus low parathyroid hormone levels. What are my 3 diagnoses?
Malignancy, vitamin D intoxication,
Now, hypercalcemia plus low parathyroid hormone level. What's the next best investigation?
vitamin D level.
Okay. Now, if I do vitamin D and I get 25 hydroxyvitamin D, what is my diagnosis?
Intoxication.
If I do vitamin D levels and I get 125 dihydroxyvitamin D, what's my diagnosis?
Granulomatous.
And what is the next best investigation?
Chest X-ray.
Okay, we've arrived.
Yeah.
Arrived. So now the next question, the next thing is this. You have to be able to construct an effective initial management plan for a patient who presents with hypercalcemia. And if you're able to solve this question for me, then you are good. So let's go through this question quickly. A 56-year-old gentleman was seen in the ER after a colleague asked him to come due to his blood work. You notice that the calcium level was 7.5. His blood pressure was 170/90, increased skin turgor with hallucinations. What are your next steps in management? Increased skin turgor, what should that tell you? The patient is
Dehydrated.
The patient is having hallucinations. Do you remember the 4 things? Groans, moans. So what is this patient doing with hallucinations? What's he doing?
Moans.
Okay, good. And then the patient's blood pressure is high and the calcium is high. So what are my steps in the management of a patient with hypercalcemia? The first thing, check ABC. After that, fluids. ABC, fluids. ABC, fluids. This patient has hypercalcemic crisis. I'll check the ABC, I'll give fluids. I'll give a lot of fluids. This patient, I'm going to give him a lot of fluids. Give a lot of fluids, doctor. Give a lot of fluids. Hypercalcemia goes with a lot of fluids. Give a lot of fluids. Then you can, before you give any medication, give your fluids. Give fluids. Then you can do your calcitonin, because the calcitonin will inhibit bone resorption. Because remember that we said that one of the causes of hypercalcemia is if there is bone reabsorption. Do you remember that? So if you give your calcitonin to prevent that, then you can also give bisphosphonate, which will decrease the mobilization of calcium from the bone. And then you can give steroids if the patient has vitamin D toxicity, or if the patient has a malignancy, or if the patient has a granulomatous disease. Doctors, please, has calcium abnormalities become ridiculously simple for you today? It's a stepwise approach to this. And then, previously there was talk about giving diuresis, but the current evidence shows that there is no evidence which supports common practice of using furosemide or other loop diuretics to enhance calcium 2+ elimination. Diuretics can worsen volume depletion. Because remember, this guy had skin tergo, like skin tenting, he was stuporous and all that. It can worsen hypokalemia and can worsen hypomagnesemia. Therefore, the use of loop diuretics for malignancy-related hypercalcemia is no longer recommended. So I have a question. You have a patient who presents with hypercalcemia crisis. After you check your ABC, what's your next best step?
IV fluids.
IV fluids.
IV
If
fluids,
hypercalcemia crisis is as a result of malignancy, what will you give?
Steroid.
If you want to prevent bone resorption, what other 2 medications can you give?
Bisphosphonate.
What have you learned today?
Stepwise approach of investigating hypocalcemia and hypercalcemia.
Beautiful. And then, so let's do some rapid fire. After constantly complaining about back pain, I'm reading this question so that we all solve it together. After constantly complaining about back pains to her previous family physician, who she believes has not been helpful enough in dealing with her symptoms, a 58-year-old Comfort comes to see you. Despite it should be her history of motorbike accident 1 year ago, you decide to order serum calcium, which comes back as 8.8. So that is high. She's a known hypertensive on bendrofluazide and has a history of kidney stones. What is her diagnosis based on the lab results? Let's go. What's your diagnosis?
Hypercalcemia.
Good. So this same patient, what's the most appropriate next step? List 1.
Parathyroid hormone level. Serum.
Can you imagine? Okay.
Yeah.
Parathyroid hormone levels were flagged to be high. What is your diagnosis at this time?
Primary hyperthyroidism.
Primary
Fluids, because
hyperparathyroidism.
8.8.
What?
Primary hyperparathyroidism.
Yeah, primary hyperparathyroidism. Okay, good. Okay. And then what are 2 commonest causes of this presentation? So let's take it from there. After constantly complaining, she's known hypertensive and on bendrofluazide. So this patient has hypercalcemia. What are the 2 commonest causes of hypercalcemia?
Malignancy.
Malignancy and what else?
Malignancy.
Primary hyperparathyroidism. Beautiful. Okay. What physiological processes generally cause elevation in serum calcium? And I'm going to read this. Accelerated bone resorption. We learned that excessive GI absorption and decreased renal excretion of calcium. Do you remember that? If the kidney is not getting rid of calcium a lot, and if there's excessive GI absorption, and if there's accelerated bone resorption as well. Okay. The normal range for calcium level is 2.2 to 2.6, 2.5 something, you know. It depends on what they are doing. So calcium metabolism is mainly regulated by which 2 hormones?
Parathyroid hormone and calcitonin.
That's vitamin D, parathyroid hormone levels. And you remember that when we're doing our investigations, we didn't even do calcitonin levels. Remember that we did parathyroid hormone level, and then if the parathyroid hormone level was low in the context of hypercalcemia, what did we do next? We did vitamin D levels, right? Good. What's the most common cause of hypercalcemia in a patient in a hospital setting?
Immobilization, mobility.
Immobilization.
Come on. We talked about 2 common causes of hypercalcemia. And we said that it's primary hyperparathyroidism and then cancer, right? So malignancy associated hypercalcemia. And we've learned about the commonest malignancies which causes. Look, doctors, keep things simple. Keep things very simple, please. Which thyroid condition can also cause hypercalcemia? We learned this as well. Thyrotoxicosis, beautiful. What granulomatous diseases are associated with elevated calcium? Select as many as apply. Sarcoidosis, can it
Tuberculosis.
Yes.
Tuberculosis, can it cause it? What about coccidioidomycosis?
Yes.
What about paracoccidioidomycosis? So in other words, all of these can cause hypercalcemia. Of course, immobilization is not a granulomatous disease. That's why we left it out. Doctor, are you seeing the things you've learned? We are just going through it. Okay, what general symptoms must be sought in a patient with hypercalcemia? Constipation.
All.
Yeah. So constipation, fatigue, depression, polyuria, polydipsia, dehydration, anorexia, nausea, muscle weakness. These can all be seen in a patient with hypercalcemia. All right.
Bones.
What rheumatologic conditions can occur in patients who have hypercalcemia?
Mm.
Hey, if the patient is depositing too much calcium.
Osteoporosis.
Gout.
Gout.
Gout and pseudo gout and chondrocalcinosis because there's excessive bone resorption, right? And what is primary hyperparathyroidism? Primary hyperparathyroidism is increased parathyroid hormone secretion, commonly due to parathyroid adenoma, lithium therapy, and less often due to parathyroid carcinoma. So, doctors, it's been.
I have a question, sir.
Please ask your question.
Okay, I know that you said immobilization causes hypercalcemia, right? But I know that immobilization will lead to rhabdomyolysis, right? And then it will lead to hyperphosphatemia, right? And phosphate is supposed to inhibit calcium. So I'm thinking that it's
But remember that the reason for the hypercalcemia is not as a result of the, but remember that the reason for the hypercalcemia is not necessarily as a result of the hyperphosphatemia. The hyperphosphatemia is secondary to the rhabdomyolysis. The hyperphosphatemia is secondary to the rhabdomyolysis, right?
So what causes the hypercalcemia in that case? Is it
muscle breakdown? The muscle breakdown. The muscle breakdown.
Okay.
Yeah. Yes, Dr. Cosmas.
Yeah, hey, Dr. Bruni. I'm wondering, what condition do we order for serum ionized calcium?
So at times, in a patient who may have like hypoalbuminemia and all that, you can request for the serum ionized calcium. Because the albumin levels are abnormal, it will affect the readings you are going to get.
Okay. Thank you.
Sure.